Hi everyone, we're going to get started. So thanks to everyone for joining us. We're going to start a few minutes late, but we'll pick up time. This is my conflict of interest. Just want to start out by acknowledging the lands that we are on and want to recognize the Treaty 6 territory and the homeland of the Métis. So it's a pleasure to be here. Thank you all for coming. It's a great session lined up for you. I'm just going to spend about 5 or 8 minutes setting the stage, the context, and we have 5 wonderful presentations, and then we're going to open up for questions and discussion. We're really excited about what's happening, where we are in the stage in Canada. We all feel that testing really needs to be scaled up and people need to be linked to care, and so you're going to hear about some really novel approaches to that, and we're excited to get you engaged in a conversation afterwards. Just set a concept, my slides here look a little weird, but just to recognize the international context of the 90-90-90 targets, and the UK now has reached its targets. And if you watched the State of the Union a few months ago, the US is wanting to end the epidemic. So what are we doing in Canada? Well, in Canada, we've been working through a group that CANFAR has been supporting the last couple of years to look at how we can think about the efforts to get us all together, understand what's not happening and what we can do about it. And there's over 23,000 people that are falling through the cracks. We know that over 9,000 people are undiagnosed, and there's over 13,000 people who are really not in care and getting the right kind of care, and there are people that, despite being diagnosed in care and on treatment, aren't able, for a variety of reasons, be able to be suppressed. So there's lots of things that we still need to do. So what do we know? And so this was part of a context of looking at how, and there's a national or a federal strategy going to be coming out, I think even as early as next week. We were asked to look at sort of what are the research priorities that needed to be focused on. But as we brought this group together across Canada, it was clear of what we already know. And these are things that everyone in the room is very familiar with. Where are we with testing? What do we know about testing? What do we know about the effectiveness of treatment? What do we know about stigma? What do we know about the barriers to getting people access to care? So these are the things that we really do have the knowledge and tools. It's about how do we scale up. And as I'm looking at my slides here, they don't look good here. Do they look okay there? Yeah, okay, because they don't here. So just to set a context, we have 4 goals for this strategy, this action plan, and what you're going to hear about today is really focused on testing. And we believe not only do we need to reach 90%, but actually 95%. That is what is going to help us turn the tide. And for all of you know already that we sometimes think about these things perhaps too much in isolation, that you look at the cascade and think about it on the one side and what do we do for prevention. But it's very clear, and everybody knows this, but we really do need to integrate these much better. And testing for people who are negative, we want to keep them negative, and we want to make sure that those people get access to care as well. So not that everybody doesn't know that already, but I think we need to be much more thoughtful and intentional about how we make sure that people get tested and linked to the care that they need, the mental health support, and other variety of health and social services. The third and fourth goals of our efforts are looking at how do we make sure that people living with HIV thrive, and stigma is still a huge barrier. It's alive and well, and there's lots that we need to do. So our efforts are really to sort of think about how do we sharpen our focus in prevention, testing, and linkage to care. So what is the evidence? And the evidence is really striking, as you know. There's recent work from JAMA, from Lancet, about the benefits of the U=U strategy, effort, the message, the benefits of treatment. Science breakthroughs are just remarkable. Where do you have something so convincing that needs to be communicated, promoted, understood better so that people can actually make good decisions for their health. And then clearly the recent results too around, again, around ARV treatment and the benefits of this, and it's just remarkable science that is going on around the world. When we think about the undiagnosed, again, this is where we really are focusing our efforts. In the next slide, I'm going to show you some recent data from Irene Hall and CDC, really about the emphasis around reaching those undiagnosed and those people who are not really in care. But these graphs and the heat maps clearly show how important reaching the undiagnosed is and what efforts they've had, how successful they've been in reaching the undiagnosed in Australia. These are the kinds of things that we need to do here in Canada. And so in this graph on the right, 80% of new transmissions in the US have been modeled to be the result of the 15% of people who are undiagnosed and those people who are in care and or not stably in care. And so, if we think about our undiagnosed rate being at the same rate, these numbers may not be too far off here as well. So these are the cracks that we need to address. And so we think about our approach to testing and linkage to care. What is the sort of implementation science framework? And we've been very fortunate, all of us here have just received a large investment from CAHR to look at a network, support a network and testing and scale up, and you're going to hear these exciting examples of that in a few moments. But we all know that one size doesn't fit all. We need to bring the test to the people, and that test, it's not just about testing, but it's about making sure that people are linked to care when they need it, where they need it, how they need it. These are all the simple pragmatics. But we have such a variety of testing options that we need to make sure that people have available to them and it can make good decisions about. I just want to emphasize the wonderful work in Canada that's happened across the board and sort of looking at how you think about reaching the undiagnosed, and Katie's done some really nice work here. And then all of these articles in the summary, this is from last year. When you look at the evidence, and it comes across our desks every day around self-testing and point of care, the value of it, the effectiveness of it, the acceptability of it. We don't need any more studies. We need to look at implementation and thinking about pragmatic solutions. So what tools are available to us? Well, we have only one point of care test available in Canada, and that really needs to change. There are 1.7 million HIV tests that are done every year, and only 5% of those are point of care. Contrast that with the US, where over 50 or 60% of testing is point of care, where there's 5 or 6 approved or more. What was striking to me is to hear the recent numbers from Biolytical that the numbers aren't going up, but down. That point of care used to be 90 or 100,000 test kits a year. It's down to 59,000 last year. Well, that's just appalling to see that number. That should be 590,000 or more. So these are the things that we really need to change. The last couple of slides really just emphasize the really good work that Jackie Gahaden and her group have done, looking at what are there are certain provinces that still don't have access to point of care. There are key issues, policy and funding, that need to be addressed. And we know from examples, and we see this, we don't want to be the land of pilot studies, but we know that there's clear evidence of how effective point of care is. There's a nice report by Mark Gilbert and BC CDC showing the effectiveness of point of care. And John Kim has been following sort of the implementation of policies. When have you last heard about what's happening and sort of anticipating that point of care or self-testing will be available on the market, and what are the policy barriers that are still there that we need to address? So these are things that we really need to get on because it's coming. So just to end on, I think it's very important that we all band together and provide leadership, that there's a context for how we do this. It isn't just about research and implementation, it's about how we do this, how we work together, and it's an incredible community across the country. And you're going to hear more about those examples of how effective we are working together. And just to say at the end, if we're going to have real life impact, it really is getting people up to the microphone. This conversation needs to be scaled up very significantly. We need to hear people talking about it. So with that, I'm going to ask my colleagues to come up and present, and welcome to get into the conversation about their work after. So, John?
So, thank you, Sean. So, as I've traveled on Turtle Island, I've come to the realization that it's not enough just to acknowledge the lands that we're on, and in this case, Treaty 6. So in response to the Truth and Reconciliations call to actions on healthcare, specifically TRC number 18. As a federal government employee, I do acknowledge and recognize that the current state of healthcare, namely the health inequities that exist in our Aboriginal peoples, is a direct result of previous government policies, including the residential schools. Sean definitely has set the tone in terms of if we're going to make a further dent, not just in the HIV world, but in terms of reducing other STBBIs, we need new innovations, we need new strategies. Continuing to just do more a full frontal assault on HIV, just using standard phlebotomy and rapid HIV testing is just going to lead to, blunt force trauma. So what we need is actually new innovations, and I mean not just innovations in terms of testing, but innovation in terms of policies, guidelines, community engagement, et cetera, et cetera. So it's not just the first 90, but it's the second and it's the third. Now, I'm just setting the tone in terms of examples of what some of these testing innovations will entail. My panel members are going to be much more able to speak to that. What I'm going to talk about in the remaining time is the following. Each of those previous testing innovations that I discussed could be considered as disruptive innovation when it comes to testing. And if anybody wants to ask me what I mean by that during the Q&A, please do so. But you kind of get the idea. And what I'm going to be talking about is what distinguishes dry blood spot testing versus any of the other innovations is that I'm going to be describing about things that have already happened and are continuing to happen, and the way we see it will expand versus any of the testing interventions or innovations that you're about to see. And just for those who may not be familiar, when it comes to dry blood spot testing, it's as simple as it sounds. So essentially, you prick the end of a finger, you drop five drops of blood on a special filter paper, and by the way, it's the same paper that's used for newborn genetic screening. Once it's dried, you essentially just send it up to us. We have validated methods, and I'll show you the testing method for which infectious agents we've validated for, and then that's it. It really, decentralizing testing does not have to be rocket science. It does not have to be complicated. And as I'll show in a couple of slides, we're actually seeing the success of such a simple innovation in terms of testing. In terms of the testing menu, our pedigree in using dry blood spot testing is not since we moved to the prairies from Ottawa about 4 or 5 years ago. It's based on our use of dry blood spot testing for all the PHAX track surveillance studies for the past 10, 15 years. So to date, we've tested thousands, if not tens of thousands of these cards. It's only when we moved up to the prairies and actually, frankly, set foot on First Nations and Métis communities and started to see where the lack of access to bloodborne testing, which everyone else is entitled to, does not necessarily exist. So in terms of what we have validated, on the lower left, HIV, hepatitis C, we've recently validated a syphilis screen off of dry blood spots. In terms of future innovations, what we plan on doing later this year is HbA1c. So anyone who's not familiar with that, A1c is a much better marker than glucose for prediabetes and diabetes. Now, the reason I have this slide up here is for the following. We would have liked to have been able to test every STBBI off of blood, off of this card. We know we can't do that. So instead of a one-card test all, the innovation that we're now thinking about is a one-visit test all. So here's a scenario. We know that we're able to engage individuals using the dry blood spot where they would not have wanted to engage phlebotomy. So the individual is here, you get most of the bloodbornes, HIV, Hep C, Hep B, syphilis. You have that individual there, you get them to pee in the orange cup. So there's two ways. You can either use that as the sample, or you can actually use the same filter paper, dip it in, dried urine, and you have your Neisseria and chlamydia. Then, if you have a woman in front of you, childbearing years, you can also do self-collection for HPV. So in one visit, you have what, 3 to 5 different STBBIs. Throw in the A1C, and then you have a chronic disease. Is that far? Is that far in terms of realization? I don't think so. So this is the kind of innovation. It's not just the testing, but it's how we roll it out. That you know, in terms of the innovation that we're trying to think at the JC Wilt, and this is the way that all of my colleagues are trying to implement in whatever work that they're doing. Syphilis, our validation of syphilis couldn't have come at a better time. I'm stating the obvious when I see that there's outbreaks of syphilis right across the country, and especially on the prairies. Nowhere is that more prevalent than in Winnipeg. As you may or may not know, we already have 12 cases of congenital syphilis, and we actually may have more. Although we're an HIV lab, ever since anyone who's in HIV knows that you cannot think of HIV just in terms of an infectious agent. And as other talks have described, we have to adopt this endemic approach. So for us, it's syphilis. Syphilis and HIV have that concomitant role. So we anticipate that our syphilis testing is going to be a significant component of our testing as we move on, not just in Manitoba, but in other places. Okay, one example, probably the best example where I can see the adoption of dried blood spots has been in Indigenous communities across, really from Northwest Ontario out to the BC coast. It's ironic that we are now having this meeting in Saskatchewan, because in fact Saskatchewan is probably the model for how Indigenous communities have adopted dried blood spot testing and rolled it out in their communities with a great deal of success. And I don't have time to talk about the other locations. However, there's other applications of dried blood spot testing. So as an example, in February of this year, Health PEI and Peers Alliance implemented dried blood spot testing at an LGBTQ2 event, and they now want to use this to roll out in other LGBTQ events. Other Atlantic provinces are also considering the same as well. In terms of systems implementation in Saskatchewan and Ontario, dried blood spots have gone from pilot to systems implementation. So what I mean by this, as an example, Saskatchewan, pick a site, any site, the dried blood spot cards go to the Roy Romanov in Regina. It's entered into their databases. We're a national reference lab. Whatever samples they happen to be sending us that day come to us. We test, final reports, they go back. So everyone is happy. Public health, the linkage to care piece is addressed, et cetera, et cetera. So we anticipate that other provinces, and we're at different levels of engagement with other provinces regarding dried blood spot testing. This is my last slide. I have a personal note and a kind of a general comment here. So you're going to sense a sense of optimism in terms of the testing. I've often used that term, this is going to be a watershed year for testing, not just for dried blood spot testing in Indigenous peoples, but everything, as you'll see in the next few minutes. But I'm constantly reminded in my personal journey in terms of interactions with our Indigenous peoples that if you remember the testing menu about one visit, test all, the fact of the matter here is that not everyone may want that. So even though I'm excited in terms of the dried blood spot experience and what we can or cannot test, the fact of the matter here is not everyone may be receptive or wanting to that. So there's got to be an issue of making sure that there's a community engagement piece, there's a community readiness. But the point I want to make here is that not everything we do with our Indigenous peoples is research. So as an example, I use dried blood spots. However, the two most important things that we need to do always is a community engagement to make sure that community is ready, as well as establishing a relationship to make sure that whether it's research or whatever, that all parties know what is going to happen with that specimen, as well as the test result that comes from that. Chimegwich, merci beaucoup, and thank you for your attention.
Thanks very much, John. Nate.
Thanks. Hi, good afternoon, everyone. My name is Nathan Wachowski, and we'll just go back to the beginning. I just want to add my acknowledgement to this territory. And particularly, when I think about territorial acknowledgement, I like to try and think about that as just one particular step towards thinking about what are some actionable things that I can do as a settler scholar in this. And so particularly in my work, where I work with a lot of gay and bisexual men, I think about how when we erase or ignore or don't create visibility or space for our two-spirit folks that are within our communities, that is an example of an ongoing form of colonization. So just a small thing. And I'm here to talk a little bit about thinking about context and process in terms of the role of community as well as events-based testing options. So if we were kind of asked, Sean tasked us to kind of think about a 5-year vision. So I feel very humbled to be asked to do this, so that's where I would start. But these are some of the things that I think about in the few years that I've been doing this work as being critical to actually seeing success and equitable success in terms of where we go. So one is around having strengthened community infrastructures. And this particularly for me needs to center peers and build capacity both within community, but also for the folks that want to work with and support community. And then thinking about scaling up and scaling out in terms of event-based testing. And I'll talk a little bit about some of the experience we've had doing that. Folks will talk about increased testing options more than me per se, and so I'm not going to focus too much on the technological piece, but I do think we need to think about how each of those gets integrated in different ways into our community fabrics. And ultimately for me, I think the vision also needs to situate this within a broader framework around sexual health and harm reduction. So some of those things in terms of event-based testing. I get to serve with the Community-Based Research Center as the PI for a study called Sex Now. Some folks may have heard of it. And it has been a community health survey for nearly 2 decades. This survey actually started at Pride festivals in British Columbia in the early 2000s. It went online when everyone else started dating online. And we've gone back in person this past summer to do data collection. And for me, I think what's really important about events-based testing is when we went back in person, we had a long process of conversation with various folks across the country around coming into that space. Okay, that's not our space as researchers. We didn't create Pride festivals. And so thinking about if we're going to go in and do research in this area, how can we do that in partnership and in honor of the different protocols that are there? For me, it's also important, I think, that during this aspect that we often will have an adage to say, if we build it, they will come. But ultimately, I think we actually need to get out of our homes, out of our houses, and out into community where folks are. I think if we really want to reach folks and get to people, then we need to go to where they're at. And Pride is one of those major gathering places. And so in this kind of concept of high volume, we get to talk to and experience and work with during dozens, hundreds, thousands of people in a really short period of time. So it's high efficiency in that regard. These were our partners for the 2018 Sex Now survey. So folks from across the country, we went to 15 different communities, urban communities across Canada to their different Pride festivals and attended various events within that, ranging from during booths at kind of community fairs to a two-spirit powwow that occurred as part of Winnipeg Pride. And these partnerships are critical. So CBRC works to connect and collaborate with all of these organizations. Without these partnerships, we would not be able to do the work. And I think those relationships are really important to recognize that if we don't build the relationships and continue to steward them and establish new ones, then we're going to be limited in our ability to have impact. We also worked with John's lab in terms of doing the dry blood spot testing, which I'll talk a little bit about. For us, this was also really important of thinking about the value of peers. So I think this conversation has come up at this weekend. There were some great presentations, one from Chiwos around the value of formal peer support. And I can think of many others as well. But for us, it was important that we do this using peers and folks that want to work in allyship with our communities, because it creates a level of comfort and safety, and also is about, providing capacity. And so we did some training at each of the sites that we did, supported through John's group as well, in terms of this kind of train the trainer model. Dry blood spot testing, as John said, it's not rocket science. Any gay, bi, queer, two-spirit person can do it, and so can you. And so we went around the country and we had hundreds of volunteers who engaged in this testing. During the ability to go and sit across a table and spend a few minutes holding someone's hand or asking them to clap it to warm it up when it was raining during many of the Pride festivals, and holding their hand for a few minutes while you talk through them about the consent process and then the collection process. I think it creates really short moments of human connection that were very valuable. And so for us, that aspect of having peer-based testing, I think, is really important. I also think about this aspect in terms of the fact that we need to realize that there's a broader piece around supporting capacity building that's important. For me as an academic, during it, I come also as a gay man to this work. And so I learned a lot about how to do community-based work and why that was important and how we should all be doing that through a program called Universities Without Walls. I can see some of my mentors sitting at the table over there. So thank you. And thank you to the many folks in community that come and give us a lot of patience in terms of letting us academics unlearn some of the things that we've learned through our process of formal education. I also want to recognize some of the community programs. These are 3 that the Community-Based Research Center has. But there's many different community groups across the country doing capacity building work that builds leadership within communities that is totally necessary as the infrastructure upon which we can leverage any kind of impact. And I think that work, so that training needs to be community-based. It needs to be cross-sectoral. So I've talked a lot about community, but we also need to think about how we bridge capacity for providers, healthcare systems, and policy folks across the gamut. So this is not just about a community in that sense as well. And so more testing options. So this is something that we've heard from the community for a long time, and it's exciting, I think, as John said, I mean, to think about that there might be some real shift, some real significant shift in access and opportunity. When we did the survey last summer, when we did dry blood spots with the community, 87% of guys agreed. So these are folks who came out to Pride to celebrate during queerness, queer activism, community connection. They took 20 minutes to do a survey, hoping it would have been shorter, but it's hard as a researcher. And then they provided a dry blood spot and spent half an hour with us to do that. I think it speaks volumes to if you create an opportunity and you create a good relationship that people will take that up. We had an incredibly high validity in terms of the sample collection, which was great. And we also gave people the option to get their results back. This is something that had really not been done in previous kind of biobehavioral survey or surveillance studies before. And we were expecting maybe a third of people would be interested in this, and we had over 2/3 of people provide some form of contact information to get their results back. So to me, that speaks to the fact that people want this, okay, and that it's therefore our ethical obligation to provide it, and to think about this in the context of a research study and being a bit of a pilot, to then how do we go into that implementation phase that John talked about. In a or previous cycle of Sex Now, we also asked folks about at-home testing. 70% of guys said that they were interested in an at-home test, and that 1/3 of them would prefer that as their test result. And I think one of the things that I've been trying to think about in the sense of implementation is also shifting resources. And if there's a bunch of folks who are totally happy doing a self-test, think about how that could open up the space that we have in our clinics, the time we have with providers to focus on other folks who might benefit more from that. So I think this is a real opportunity for us to think critically about this. And other folks will talk about multiplex testing, but very much this is not just about HIV. We did hepatitis C and HIV testing in this study last summer. And then in terms of broader frameworks, I just want to give a shout out to one organization that I work with quite a bit, the Health Initiative for Men. They're a men's health organization in Vancouver. Their model focuses on 4 areas of health: physical, social, mental, and sexual. And I think this aspect really connects that these issues cannot be disentangled and pulled apart, and that what really brings us together and connects us as a community and connects us to why we seek healthcare and wellness are sometimes not the things that might organize our conference here today. And so we need to think about those pieces. This also, for me, really ties into the aspect of linkage to care. This is not just about linking people to get access to HIV treatment or to PrEP, but a much broader piece about thinking about what supports people need to be well in their life. And that really, to me, ultimately is how we actually respond to individual and community priorities. So how do we get there? To me, I think a central component of Sex Now, as we've thought about this, is about offering choice and respecting autonomy. I think that's important both at an individual level and a community level, that we listen, and then we listen some more. And I think that's important in the context of just all of the work that we do, but also in terms of thinking about how do we prepare for reactive results. I think this is something that's come up quite a bit in our conversations, and it's obviously something that's important. And that when we have those conversations and really think through how well can we support people, we come up with really good systems and ways of doing so. But that takes time and that takes conversation, so we can't rush it. And that ultimately this is really about partnerships and collaboration. So we would not have been able to do this study without all of the folks that I showed on the slide earlier, without the partnerships with the lab. and so on and so forth. So we need to continue to expand those and think about this. For me, I'm kind of talking about this from the point of view of one study and kind of one organization and one population, but we know that our populations are not these distinct silos, and so we've been doing work in ours to try and create more space for Two-Spirit folks within our surveys, thinking about how we recognize them within the survey, how we provide response options that make sense for those folks. And I think we all need to do that in all of our respective silos, is to reach out a bit more, to try and get out of our silos and realize that within all of our communities, we have a diversity of ethno-racial communities, a diversity of genders, a diversity of sexual orientations, and so on and so forth. And then this concept of scale out, scale up, and scale deep, I think Sean kind of mentioned this aspect of being known as a country of pilot tests. So for me, one of the things I'm really interested in is how we take some of the things we're learning and we continue to learn with them and we continue to scale with them, and that we don't just stop there and say, great, we've gotten a paper out of this pilot program, and now it's someone else's responsibility to do that. I think that's totally our responsibility. And lastly, I kind of talked about this kind of intersecting aspect within our communities, but we need to work about this broadly. It's not just about HIV stigma. It's about colonization. It's about racism. It's about homophobia. It's about transphobia and classism and all of those things. So that's kind of my points, and we'll save comments, questions, and discussion for later.
Thanks very much, Nate. We'll have Nikki come up, and it's Nate's birthday today, so why don't we give him a round of applause.
I love technology, but I need to figure out that this works. Okay, it's 2019, guys. Are we ready for HIV self-testing in Canada? Yay, thank you. Thank you. So my case is made. I don't need to talk anymore. So Sean wanted me to kind of first talk about what is happening with HIV self-testing in the world. So the story with HIV self-testing began in 2012 when FDA approved the first Rourke self-test. Little did they know that they were releasing something to the big wide world that is going to disrupt the testing world. And soon after, in 2013, the Gates Foundation organized a meeting in London, which some of us attended, and really talked about how are we going to do this? How are we going to scale all of these self-tests to the world? So there was a lot of evidence even then. We needed to define HIV self-testing, so it was defined as a process by which an end user buys a self-test, conducts a self-test in the comfort of his or own private space, and interprets the self-test on his or her own. So a confirmatory test was reactive test needed confirmation, and a non-reactive test was considered negative. And soon after, there was a race to kind of really make sure that, we collate all the evidence so that we could release the HIV self-testing guidelines. And these guidelines were released in 2016 at the IAS meeting in Durban with evidence that there wasn't a lot of evidence from clinical trials, but there was enough evidence that was graded and HIV self-testing was approved. And shortly afterwards, being a part of this process, I feel like an HIV self-testing historian here, but I couldn't imagine the amount of the energy that was released right after that. Self-tests were marketed all over the world. Oral self-tests became very popular, especially in Africa. UNITAID funded this 22 million project in 4 African countries. A lot of our self-testing projects also got funded, and there was just so much of momentum in the room that it was impossible to curtail the infectious energy of HIV self-testing. Yes, I'm totally biased, but bear with me. So self-testing strategies, there are 2 kinds of testing strategies that are in use today. One is the supervised or the assisted self-testing strategy, and the other is the unsupervised, unassisted self-testing strategy. Unassisted is what we understand in this part of the world. In Canada, oral self-tests available in the pharmacy, especially in North America, and a person who buys it, does it in the comfort of his or her own home. The other strategy that is more popular, especially with HIV testing organizations, is the supervised or assisted self-testing strategy. Some people are comfortable with the notion of testing, but they really want somebody in the audience or somebody in the room that can help them, and so supervised became really popular. So what's happening in 2019? There are more than 250 studies across the world on HIV self-testing. There's data on self-tests that have brought, like, there's increased uptake of HIV testing. There's more than 2 times, it has doubled the uptake of HIV testing, HIV self-tests, and it has led to increase in frequency of testing. It has also led to bringing people into care, but not to the great extent. So linkage data is certainly weak. So what's happening now? What did we do at McGill? So I've been looking at HIV self-testing since 2006. And so because linkage data was weak, we decided to look at innovations. And then was HIV Smart that was born as a digital strategy, which could be operationalized from smartphones, from laptops, tablets, and it provides pre-test counseling. It also allows you to conduct self-tests in the comfort of a private space. Also provides post-test counseling. It's stored on a confidential server. We have a HIPAA-compliant server that stores all the data, so it's very, very secure. And it's currently formatted with oral self-test because that seems to be the very popular self-test, but it can also be adapted, and we are adapting it for blood-based tests. It's a multilingual platform available in English, French Canadian, Swahili, Xhosa, Zulu, and of course other languages. So the first prototype was tested in McGill students, and the second prototype was tested with funding from Grand Challenges Canada and healthcare professionals of South Africa. Shortly afterwards, we got the CAHR funds and we tested it in MSM populations at Lac Choual, and the feasibility data was in the high 90s. People wanted to take it home. They just loved the notion of testing. They even wanted to test their partners, their friends, and bring everybody. So even though we budgeted for a 6 month of recruitment, we were able to finish the recruitment in 3 months. Talk about recruitment. Then we got funded by Grand Challenges Canada to take this strategy to scale in South Africa. And right now we were talking scale, because there were a lot of studies that hadn't really proven transition to scale. With this, as part of the Government of Canada's requirement, we raised co-funding money from Government of South Africa. They were also keen to see how it happens at scale. So what did we do? We built a bigger platform, I almost thought at one point we had firewalls in, and I had built a Ferrari and I was trying to run it on a dirt road. So it was very secure. It was operationalized through, so we tried 2 kinds of strategies, and the work is in press, so I have to, I didn't put the data out there, but I can talk about it. So we we did a transition to scale cohort study where we followed 1,500 participants in the conventional cohort and 1,500 in the self-testing cohort. We gave them a choice of 2 self-testing strategies, the supervised strategy, which could be done in the clinic, or the unsupervised strategy where they could take it to their homes or offices or any private space that they wanted to test. Guess what happened? In the beginning, there was a little bit of resistance towards giving and empowering individuals, and we were recruiting people who were showing up from community township populations of Cape Town. So as soon as we rolled out the strategy over a period of 3 months, we did well with the supervised strategy, and once our healthcare workers and entire staff were happy and comfortable, we started rolling out the unsupervised strategy. We asked people to get their smartphones, and you may be surprised, people in South Africa, especially in urban South Africa, they actually have 2 smartphones. They don't have 1. So we were able to load that onto their phones, and then we gave them the self-test and the app to take it to their homes, self-test in the comfort of their home, and also seek linkages to care. The linkages were operationalized through the app and by a service of healthcare counselors that were available 24/7 to answer their questions. So what happened? With this strategy, we were able to get 5.5 times more referrals to self-test compared to the conventional strategy. So that's an indicator of expanded access. We were able to detect 1.5 times more new infections. A greater proportion of new infections were detected in the unsupervised strategy compared to the supervised strategy. And we were able to, most importantly, we were concerned whether people will come back and whether they will be linked to care, but we were so happy to see that all the unsupervised participants came back to care. Our linkage data is one of the strongest in the world. 99.7% of our unsupervised self-testers came back into care. So we asked a team at Maastricht University, they do qualitative research on point-of-care tests, to independently look at how was this digital innovation really impacting our patient populations, and why was it that they were keen on, doing a combination strategy? And what they found out was that they actually felt supported. And this paper just came out 2 weeks ago. They felt supported through the process of testing, and the way that we had built in choice, it allowed them to exercise their, they felt that the app-based strategy allowed them to exercise portability, they could test at their own pace, space, and convenience. So armed with that, now we are at this point where IPAC is interested in taking the strategy to fast-track cities. And we are also going to scale this strategy with Sean's and John's help and Nathan's help and everybody across Canada. So we're very excited. So Sean asked me to paint this vision of HIV self-testing, and as a visionary, I enjoyed visions. Don't ask me about to-do lists, but visions I can do. So I think in 5 years, bear with me, I'm dreaming that affordable self-tests are available for every Canadian. Yeah? Both blood-based and oral tests. Point number 2, service delivery with HIV self-testing is in place. Linkages are being operationalized. We use all kinds of models. We can use peer navigator models. We can use app-based strategies. We can use pharmacy-based testing, outreach-based testing. There are so many options. So we optimize whatever we have available to provide service delivery. 3, all the at-risk populations are provided choice to test, and they are proactively testing at their own pace, space, and convenience. And we have achieved the first 90 or even 95 of the 90-90-90 targets, and we are declaring it at the next IAS conference. Okay, more ambitious. So we will have 2 kinds of strategies. We'll provide supervised self-testing strategy to all community-based organizations, private clinics that are interested in adopting it, community-based outreach clinics, mobile vans, what have you. It is such a flexible strategy, it can get in everywhere. It can sneak in. And unsupervised self-testing strategy can be provided using app or digital solutions, web-based options. We can set up kiosks in clinics. We can set it up in private clinics, in doctors' offices. We'll make sure the doctors also get paid. And the outreach clinics and mobile vans. And most importantly, pharmacies. So what do we need to do in terms of to-do lists? To achieve this vision, we first need to get an approved self-test for Canada. And hopefully we will be able to do that. We are all, as they say, if you put something out to the universe, it listens to you. I think we are really sending this message to the universe that we need approved self-tests. We need to change the language and the dialogue of point-of-care testing in Canada. And I think that is a resolve. So rapid approval of quality-assured blood-based self-tests. Once we get that out of the way, we should also encourage oral self-tests. And there are about 12 prototypes that WHO is reviewing for self-tests, so we should get at least 6 of the 12 into the country. 2, impact and cost-effectiveness data. That directly feeds into policy. We don't need any more data, but we need data that changes policy, provincial policies, federal policies, what have you. 3, synergistic collaborations with stakeholders, which Sean has effectively accomplished. We continue that. We repeat that model across provinces so that we have meaningful dialogues and so that we don't really need to talk about or write another paper on why vulnerable populations are not getting access to care. We know the reasons. We just need to say how they got care and how that happened. And 4, effective and innovative service delivery models for linkages to counseling and care. They are available. There are a dime a dozen models across the world, and that can be a reality. I come from the land of Gandhi, and Gandhi said, be the change you wish to see in the world. Each one of us in this room is a change maker in our microenvironments, and I appeal to you, to the change maker in you, to really make this happen. So dear CAHR attendees, does this action plan sound feasible to you? Yay, thank you. I really want to thank Sean and John for convincing me to work on point-of-care technologies in Canada and reach point-of-care working group. Thank you.
Thank you. Thanks very much, Nikki. Welcome up, Debbie.
God, I hate coming after Nikki. So thank you very much. I'm really pleased to be here and share, I guess, my vision for how a pharmacy-based testing option is going to lead us to achieve our goals in Canada of 95, 95, 95. Here are my disclosures. So first off, I just want to ask you, show of hands, in the last 3 months, how many people have been inside of a pharmacy? Not just to get a prescription filled, maybe it was to get a Mother's Day card, if you have forgotten what tomorrow is, or maybe a carton of milk. So almost everybody has been in a pharmacy in the last 3 months for some reason, right? And I think, I won't ask you why you were there, but chances are there are people in the audience who probably availed of some of these products. So pharmacies have been playing a role in sexual health for a long time, whether it's through the sale of products that we use to enhance sexual pleasure, or other supplies that we use for to augment our behaviors. Prophylaxis. So pharmacists are providing vaccinations now. Pre-exposure prophylaxis is dispensed through pharmacies. If the pre-exposure doesn't work, we also offer post-exposure options like Plan B. And if you're not sure if anything took, we also do some diagnostics, thinking about pregnancy tests and testing for other chronic diseases. But what's missing here, if we actually want to think about the pharmacy as being a hub for our sexual health and supporting our sexual health, is actual testing for sexually transmitted infections and other bloodborne infections. So I'm going to propose to you how I think this can work. If you think about in your community now, where can you go to get an HIV test? Well, there are a variety of options. And I say there's a variety because they vary depending on where you live. If you're fortunate enough to have a family doctor, you might be able to go there. You could go to a hospital. Nobody wants to go there for an HIV test. You might have access to a sexual health clinic, but I would say that a lot of rural areas and smaller provinces don't have easy access even to sexual health clinics. And sometimes there are community-based options that either can offer peer testing or referral for pharmacy-based services. But there's also the pharmacy as a very accessible option. And the beauty about a pharmacy is that it's in virtually every community. So back in 2017, we received some funding from CIHR to conduct a pilot looking at the feasibility and the practical issues around offering a pharmacist-based testing option. So this is not just the sale of kits, but this is actually going to the pharmacy and receiving your HIV test by the pharmacist. So we did this study in 2 provinces, in Newfoundland and Alberta. We had 1 rural, 1 urban site in each province. We ran it over 6 months. And over the span of 6 months, we presented the data at CAHR last year, but just to recap, we did 123 tests, and we found 1 new case of HIV, and that case was found in a low prevalence province. The testing was overwhelmingly well received from clients. So we spoke to pharmacists, we spoke to the participants about what it was that they liked about the pharmacy option and whether it should continue. And virtually every participant, we had 99.8% said that pharmacy testing should continue. People were over 95% comfortable and confident with their experience with getting their test at the pharmacy. And of those who had testing elsewhere, many of them actually preferred getting tested at a pharmacy over a sexual health clinic or other interaction with the healthcare system. 75% of the people who we reached were individuals who, we used the Denver HIV risk score. So by the Denver HIV risk score, these were people who should have been tested for HIV, and over 30% of people who participated in this pilot actually received their first HIV test through the pharmacy. So I present to you that this option is feasible, and it can actually get testing to some of the people that we're missing who need access to testing. When you ask the participants what they liked about it, accessibility was huge. So a lot of people don't have access to a family doctor. There are no sexual health clinics in many areas. I'm from Newfoundland, and I can tell you we have 1 sexual health clinic in the entire province. So if you don't live in St. John's or the surrounding area, you're not getting a sexual health clinic. You probably don't have easy access to a community-based organization who can facilitate things, facilitate access to testing either. But a pharmacy does present an easy access option. The other thing that people like about it is the discretion. So I mentioned before, you might go in to pick up a Mother's Day card or a quart of milk, and that's really nice because if you live in Botwood, Newfoundland, how many of you have heard of Botwood? Yay! If you live in Botwood, Newfoundland, and you happen to be sitting in the lab and your neighbor walks in, chances are they're going to ask you what you're doing there. That's just the way we communicate. However, if you're in the pharmacy, you got an easy cover. I help people lie all the time and come up with cover stories for why they're in certain places, because that's what you have to do to help people feel comfortable and to keep them engaged in care. So if you're in a pharmacy, you might be there picking up a quart of milk, or you might be there getting an HIV test. You might also be getting a flu shot. When you go in that private counseling room, nobody knows what happens in there, and there's a whole suite of services that could be provided, including STI testing. The other thing that people like is that they don't identify the pharmacy as being a medical setting. Even though pharmacists are healthcare providers, it doesn't feel medicalized. So it helps contribute to the normalization of testing, which is what we're trying to achieve. And people feel like, I'm going to the pharmacy all the time anyway. It's an easy add-on. If they see a poster, they're curious and they ask about it. And it's quick and easy. So some of the pharmacies offered testing through appointments, others offered drop-in, but even if it was an appointment, you could get an appointment at your pharmacy a lot faster than you could typically at your family doctor. And they liked the idea, of course, that it was point-of-care testing, that they got the results immediately, that it was very fast. They liked participating in the testing process and understanding what was going on. And of course, many people also like the idea that it avoided phlebotomy, no needles. It was a very simple test to get done. But beyond that, they like the idea of being able to access testing through a pharmacy without having to go through the rigmarole of going through the system. And what we heard was that people want options. So in terms of what this can look like, I would present to you that I think there are really two sort of ways that we can approach the testing model. So the way that we did in the pilot was HIV point-of-care testing. So somebody went in, they got a point-of-care test for HIV. If it was reactive or they were in the window period, they left the pharmacy with a blood work requisition and a card listing the different places that they could go to get their blood drawn. So we immediately had them linked for confirmatory testing. And these results were then reported to, we had linkage to care plans that were very, very tight. So typically it was a public health nurse or a nurse practitioner who received those results and then contacted the client afterwards to arrange for care and treatment. In phase 2, which we're getting ready to roll out over the next year, we're going to be looking at adding on not just testing for HIV, but also testing for other sexually transmitted infections and bloodborne infections. So John's spoken to you about the dry blood spot testing option, and it's ideally suited for use in the pharmacy. So imagine that you can get an HIV point-of-care test, but we can also collect a sample for Hep C and for syphilis testing. And we can send that off to the lab and the same way get the results reported back to you through the linkage to care plan. So the pharmacy testing model really offers a lot of things. It's great to know your HIV status. There's no taking away from that, and we definitely have work to do. We heard about that. We all know that. But there's a lot more that can be gained besides knowing your status. In addition to testing, there's also education, prevention, and even access to treatment. So legislation has changed a lot over the last, even just in the last year. So pre-exposure prophylaxis is now covered by virtually all the provinces. So there's an easy access to screen people now who are at risk of HIV and get them directly connected with PrEP through the pharmacy. There's also the opportunity to collect specimens, not just for Hep C and syphilis testing, but also, as John alluded to, perhaps we also can collect samples for chlamydia and gonorrhea testing. So this can have a huge impact in terms of looking at it from a public health perspective. How can we actually get people tested for STBBIs and get them plugged in, not just for testing, but when they receive the results, also care and treatment, even through the pharmacy. In Alberta, pharmacists can now prescribe for hepatitis C therapies. So if you get a result that comes back, pharmacists can also order labs. So if they receive the test result and someone is positive, they may be able to provide Hep C care in some rural and remote communities directly through the pharmacy. So I think that's a really exciting option. We also heard from Nikki about the role of self-testing, and the sale of self-testing kits can be done through the pharmacy. So I think there's really a great opportunity here to offer a full suite of STBBI testing through the pharmacy, and think of the pharmacy as being a real hub for sexual health. So what's needed? Sean said to dream big, don't think about, don't be restrained by resources, but I'm much more pragmatic and I can't help but think about what's required. And I think that there are three real areas that we need to contemplate. One is, where is pharmacy-based testing best suited? So not all pharmacies should offer this, it's not necessary, but there are some places, based on the needs of the communities and existing resources and where those gaps might be, that the pharmacy testing option is really an ideal option. The second thing is integration with public health services. We need to view these services, whether they're offered through a pharmacy or elsewhere, as an extension of our public health system, and make sure that the pharmacies have access to linkage to care resources, that those strong linkage to care plans are in place, support services for clients that come in for testing, for reportability issues, and also for training and quality assurance. And finally, of course, we have to think about scope and remuneration issues, because the scope is different in every province. So we need to make sure that policy is no longer a barrier, that our policies enable every health provider to practice to their full scope, and to make sure that clients have access to the testing and the services that they need where they are. Thank you.
Thanks very much, Debbie. And we'll have Alex next. Thank you.
Okay, hi everybody. I'm going to start with an apology. It's been a busy couple of days for me, so even coming up with a title was a bit challenging. So we're calling this Other Considerations at this point for lack of something more creative. I have no conflicts of interest to declare. I want to begin with a territorial acknowledgement. I am a guest on these territories and have been welcomed by many Indigenous people, for which I'm quite grateful. And as we've heard from several people already, the territorial acknowledgement is not just something that we rhyme off and then move on. I've included a couple pictures to show, first of all, that Treaty 6 actually spans across provincial boundaries. You see this 1876, which was when Treaty 6 was signed. That means that we're coming up pretty close to, 150 years? And that means that we're going to have an accountability, I think, that is coming in very soon. The last picture that you see there is actually the pipe ceremony that they did with the signing of Treaty 6. And what that is signifying is that for the Indigenous people of these lands, Treaty 6 was a spiritual agreement. They went into this not just as a legal thing, but also connecting with each other. And so I think that just the way that different sides interpret things can be quite important. This is a map of Canada, and it's from the 2016 census that you're seeing the different numbers. And so basically almost 5% of people in Canada have self-identified as Indigenous. You can see that the numbers vary across the country, both in terms of absolute numbers as well as percentage of the population. So therefore, out east, the numbers tend to be a bit lower. In Ontario, you see that 2.8% of the population self-identified as Indigenous. However, it was 375,000 people. So that means that an awful lot in terms of absolute numbers of people in Ontario self-identify as Indigenous. The other thing I want to point out is that when you go up north, you can see that there are numbers as high as 85% of people self-identifying as Indigenous. That is really quite incredible if you think about those communities. However, you don't actually have to go as far north as what this map suggests. Once you are north of Prince Albert in Saskatchewan, pretty much you're looking at 85% of the population there self-identifies as Indigenous. So, and I know that Manitoba has similar numbers and so on. So again, when you're thinking about the sorts of services and how you would be going about implementing things, I think it's really important to think about the specific populations. The other thing is that I've included this map, and this is actually showing language groups. And so my point here is that long before the settlers came, we as Indigenous people had huge networks, a lot of interconnectivities, and you can see that, in fact, the previous slide, the territories and so on were basically stamped out on top of what pre-existed. And it's not only within Canada, but also Canada and the US. And so I think that, you know, in some cases, Saskatchewan and Manitoba, let's say, are having conversations because that line that has been put on the map, while it is terribly important because it is determining how health services are different between the two provinces and so on, it also is something that I think we have to be working beyond. The other thing is that when Malcolm and I are teaching about Canada, I think it's really important to realize that as a nation, we are a negotiated concept. Long before the settlers came, Indigenous people had treaties that we would negotiate with each other. And then once the settlers did come, there was a whole series of treaties that came across the country. And in fact, there's many lands within this country that are unceded territory for which no treaty actually applies, or only very old and historic ones. And so I just think that's also an important thing. In this era, and we've heard a couple of times over this past few days, we're now in the era of reconciliation. And so the Truth and Reconciliation Commission has put out 94 calls to action. There are 7 that specifically pertain to health. However, there are many of us who are saying that you can't just dissect out 1 or 2 here or there and looking at what that means. As we all know, health is broadly determined, and so education, language and culture, justice and so on, all of these things influence health. The other thing that I like to point out is that over half of the calls to action pertain to reconciliation, and that is not something that Indigenous people can do on their own. For those who were up this morning early enough, we got to hear from Willie Irvine, and he is a philosopher, a scholar, a lodge keeper of these lands. And Willie talked to us about ethical space, and he also talked about the cultural responsive framework. This is something that is, I consider, a gift from the Indigenous people in Saskatchewan, and it has much broader applicability than just Saskatchewan, and I would also suggest it has much broader applicability than just with Indigenous people. However, what they were quite interested in was looking at improving, initially, First Nations health status and eliminate Indigenous health inequities that exist in Saskatchewan. And the elders that got together to come up with this framework came up with 3 strategic directions. The first one was restore Indigenous community-based health and wellness systems. And so what you're seeing there is that, in fact, completely aside from the Western healthcare system, we have our own wellness systems that exist throughout the country. And so therefore, how can we be taking and restoring and rebalancing resources that have been right now reallocated towards the Western system? Establish a middle ground for engagement between mainstream and Indigenous systems and worldviews. And so again, then, the middle ground is this similar construct to what Willie talked about in terms of ethical space, and I'll get to that in a little bit more. But basically, this notion of 2 parallel systems that coexist and yet can reference each other and, you know, provide an integration of care, if you will. And then the last strategic direction is transform mainstream service delivery to become culturally responsive. So therefore, when I go into a hospital, I'm not in this alien medical environment, but rather something that I can actually relate to, and it reflects me. These things are all supposed to be trauma-informed, strengths-based, community-specific, and spiritually grounded. And while we're talking about Indigenous people, I would argue that a lot of these same concepts apply to most people, and therefore it's something that we should be looking well beyond just Indigenous people. Now, the other thing that Willie talks about is ethical space. And he talks about when, in fact, you're bringing these different worldviews together, that the space that is between the people, between the worldviews, when one acknowledges that the other exists and appreciates the value of the other, that is starting the creation of an ethical space. And that is something that we, as Indigenous people, consider sacred. But it doesn't just have to be between Indigenous people and Western people, it could be between 2 different cultures. One of the things that I think is important to realize is that when I was talking about the cultural responsiveness framework, I was referencing Indigenous people. However, everybody in this room has a culture. And for those who do not appreciate it, healthcare and medicine is a culture. So therefore, if and when you are meeting an Indigenous person or any patient, I think that this notion of ethical space that we could create in providing care becomes critically important. I decided to finish with a call to action, and I'm thinking back to Mark Tyndall's opening lecture, the Dr. Mark Wainberg lecture. And he was talking about how often action precedes research. And I think that we have really good evidence already that exists, but some of the areas that we're going into, in fact, we're looking at evidence generating. And so therefore, what are the different approaches that we can be taking to prevention, testing, and linkage to care? One of the things that John talks about, in fact, is that when he goes to First Nations, many of them, when they look at dry blood spot testing, are not seeing this as research. They think that the evidence is there and is sufficient, and they're exercising their sovereignty, their autonomy, and in fact are moving this into regular care. And so I think that there are going to be other instances where, in fact, Indigenous people are showing leadership, and that not only do we have to be looking at what is the evidence, but also how can we be generating evidence from things that work and that we have shown have worked. And so therefore, we're looking at prevention, linkage, testing, and linkage to care. I think we have to be harnessing innovation to create diverse solutions. And when I'm talking about innovations, I'm not just talking about testing, although there are really wonderful options that are available to us. We're looking at digital solutions. We're looking at different models of care. And this could be prevention, testing, care, and it could be things such as peer-led or nurse-led. It could also be other kinds of things that are out there. We need policy invention, programming, and research also. One of the things that I found really compelling about this team that Sean has pulled together is that it is quite broad-based and transdisciplinary. So then let me see, comprehensive, including structural competency. I don't think that we can take and just ignore the fact that somebody is homeless or that somebody has food insecurity and so on. As physicians and as a healthcare team, I think we have to be doing better. Cultural safety, humility, and responsiveness. And while I'm talking about Indigenous people, I would argue that applies to all. And reaching people where they are at. We have so many options now available through self-testing, pharmacy testing, dry blood spot testing, and so on. We should be able to test people regardless of where they are in this province or throughout the country. And therefore, not only the testing, though, the ever-important linkage to care. And what does that care look like? Coordinated Indigenous-led strategies, priorities, targets, accountabilities, to help prioritize Indigenous, Inuit, and Métis people for whom we know that there are huge health disparities in this area, but then also to be looking at the same for other populations. Thank you.
Thank you very much, Alex. So we're going to open up for questions or comments from the floor. I think we have just one microphone, and that's number 2. So we asked people if they could walk over, say your name and where you're from, and ask a question. We have a wonderful panel here of experts. We can bring the microphone to you. Here we go. Bring the microphone to the people.
Hi, it's Rick Galley with Bioanalytical Laboratories. I just wanted to offer a comment with what Debbie presented around pharmacy-based testing and the importance of linkage to public health programs. In the U.S., Walgreens, which is the largest pharmacy chain in the U.S., has a very successful program with aligning with state public health agencies in several states. And what they do is offer themselves and different pharmacies as venues, simply testing venues. And the test kits are provided by the state to these pharmacies and then offered to clients free of charge. And it's been tremendously successful in offering themselves as a non-traditional testing venue. So it really is easy to do and important to align with with public health. So there is some precedent for that. And it's something I think we can take and learn from. So I just wanted to offer that.
Thanks, Rick. Do we have a response or a comment from the panel?
Thanks, Rick. Yeah, I couldn't agree more. I think, we look carefully at what was happening in this isn't a new model in Canada, right? It's happened in the US, it's happened in the UK, and there's some great examples of how it's been integrated. I'll tell you, I'm really excited by what's happening right now in Canada in terms of the uptake and the interest, even in our own backyard. So Jackie Gahagan has organized a meeting that's going to happen just next month, of all of the medical officers of health in Atlantic Canada. And we're coming together to talk about where the gaps are, what the barriers are at a policy level, at a regulatory level, from a remuneration standpoint, and to see if we can really brainstorm around realizing some economies of scale, whether that's, they're not saying this, I'm throwing this out there, but bulk purchasing of tests, how we can integrate this into, a provincial model through that public health system. And I think BC has done that, right, through their pharmacy testing with that centralized test dissemination. So it certainly can be done, and I'm quite optimistic that we're going to get some traction.
Thank you. Mark.
Hi, I'm Mark Tyndall from Vancouver. I think that the idea that we need to allow people to get tested is extremely important, but I don't think we should get so fixated on the fact that the only reason that people should get tested is because they'll be linked to care and services, because we know down the road that's a challenging thing for a lot of people. And I think in some of our justification for this is the only reason we do it is because we need to get people in care down the road. But just the idea that people, it's their body, it's their decisions, they should have access to knowing whether they're HIV positive or not. And so we shouldn't, just not to get ahead of ourselves, the only reason we do this is that we get everybody 90 or 90,000 or whatever we want. Like, it's a human right to know your HIV status, and then after that, we want to make environments possible for people to progress down the treatment, but not get fixated on only path to care.
Thanks, Mark. Comments?
Is this on? Yep. Yes, okay, good. Thanks, Mark, I agree completely. I also think it's important to think about when the tests are negative, the opportunities that there are to actually engage in prevention and some of those discussions. I think my concern, though, in enforcing the linkage to care is that we do want to make sure that anybody who does test positive has that option. So.
Sorry, I just wanted to add to that. I agree completely. And one of the things that we heard from participants when we did the original approach study was it was great to know your status, but the other really valuable things, and arguably the more valuable pieces that they took away, was it was an opportunity to get education and to develop a trusting relationship. And we still see individuals coming back to the pharmacy and asking if the testing is going to be available again. And it's about the interaction with someone that they built a relationship with and learning how to protect themselves in future. So there's a lot more value add than just the test. I completely agree.
Thank you.
Hi there. I'm Christy Matichuk from Regina with Wellness Pharmacy. My question is more targeted at Debbie because we actually presented and did a study very similar to yours. So the question I had was specifically when you were looking at when you were doing the on-site testing, you said if somebody had a reactive, they left with a lab rec. Did you find, I guess, what were some of the barriers that you found to that? Because I know in our province in Saskatchewan, you would have had to have some sort of collaborative physician agreement. Pharmacists certainly can't give out lab recs in Saskatchewan as of yet, but that was a piece I had a question about, who to liaise with and what you're seeing there.
Hi, Christy. I was actually hoping to meet you at some point during the conference, and congratulations on the excellent work that you guys are doing here. That's a really good question. So I should say that we actually spent about 9 months before we launched the study just working with our communities. So we had provincial advisory committees established in each province comprised of folks from public health, policymakers, but also like the sexual health nurses, gave us input into how to do things and really worked quite closely with the public health nurses, the HIV clinic around what that linkage to care plan might look like. So in Alberta, pharmacists have the ability to order labs, and to react to it. But we actually made the decision not to have the test result, the test be ordered under the pharmacist's name and have the pharmacist responsible for following up. We kept the plan the same because in Newfoundland you couldn't do that. The reason we did it was we wanted to make sure we didn't bite off more than we could chew. And we wanted to make sure that we were able to get those direct connections with not just the confirmatory testing, but integrate into the HIV programs directly. So in fact, the blood work requisitions were signed off by a medical officer in Alberta or by the nurse practitioner for our provincial HIV program in Newfoundland. So in Alberta, public health nurses received the results and just through the usual process would follow up with the client and give them the results and do that follow-up. And in Newfoundland, it was our nurse practitioner who gave the results and followed up that way. But I don't know that we'll follow the same thing in the next phase. I think in Alberta, we'll probably take it a little bit further, at least in some pharmacies, to try out a different model. But that's an important consideration.
Yeah, I agree totally. It took us probably close to a year to get our study off the ground. So I appreciate that work for sure. The only other question I have, and this could be for the panel as well, is how do you guys feel about Alberta being pharmacy-wise, certainly one of our most progressive provinces that we have? What opportunities do you see with pharmacists being able to prescribe for hepatitis C?
Comments?
I know it's a big question.
Want to tackle that? Anybody want to tackle that?
All right, so I'm trying not to be the one doing all the talking. Clearly, my bias is that I think it's fantastic. I mean, I think these decisions always need to be done carefully, and you need to have the plans need to be well thought out, and I don't think if anybody has ever worked with a pharmacist, we don't go off renegade as a cowboy doing our own thing. We're actually we like rules and we like I's to be dotted and T's to be crossed. So I don't have a lot of concern that pharmacists are going to go out and start, willy-nilly prescribing hepatitis C therapy on their own without proper guidance. I think it's a great opportunity to expand the reach to hepatitis C treatment. I don't really know the full scope. It's too bad my colleague Christine Hughes isn't here, who's the lead on the Alberta side. But I think we have more people that need access to treatment than are currently in treatment. And if we can use this as an opportunity to leverage and improve access for people, then I think it's a fantastic opportunity.
Hi. In terms of things, when you're looking at an example of what has happened in Australia or say Portugal or some of these other countries that are moving quite far along in terms of micro-elimination or even macro or meso-elimination, what we're seeing is that there is a need for clear algorithms, task shifting, and some of these other things. And so I think that pharmacy prescribed is one of the options that we would have to be considering as we take and ramp up, let's say, testing and so on. So.
Thanks, guys.
Thank you. Other questions?
So hi everyone. I'm Pierre-Henri Minot from Montreal. Thank you everybody for your presentations. So as coordinator of the first fast track city in Canada, Montreal Sans Sida, I'd like to talk about the fast track we want to try with Fast Track City, actually, how we can engage cities to the response of the epidemic regarding 2020. And we try to avoid shortcuts. And so I like it, talking about Fast Track cities and not shortcuts. And so what we are experiencing in Montreal is also everybody's always agree to discuss about 90 and how people can get tested and access to treatment, and then everyone come back home and nothing sometimes really changed. So it's really a good discussion to have in each places to say, okay, folks, what are we doing in your own mission to get people on board and to know the status, and can we do something more? Can we do something else? Can we change something? Can we stop doing things to really have focused on these targets? The other thing I wanted to say is it's so difficult to get people on board, people from communities on board, concerned people on board, not only as observers and people to get feedback and to consult, but also on the place where decisions are made. And that's a real sometimes struggle to mobilize people. And it was really amazing to listen to the Indigenous presentation earlier, talking about, yeah, call me once, 2, twice, 3 times, 10 times, and keep calling because we have to be on board, and you also have to call me 10 times before I may answer. So we want, because it's easy to do a shortcut right here, to be okay, is it not answering, so we won't do this. My last point was about the data, and it's also something not so easy to share because data are 90 can show sometimes things we don't want to know, and sometimes, oh, okay, 97, the job is done here. And no, it's not. And also the data have to be comprehensive by everyone, including concerned people. And so I am also inviting everyone in this room to talk about data in a way people can understand it and be in action with it, because it's driven the decisions, the way to go, the places to go. And so, yeah, Fast Track Cities are ambitious, and I say hi to my friends in Toronto who are working on it too. And so, yeah, I think it's possible, Nikki. So, yeah, thank you very much.
Thanks for your comments. So we're almost out of time, so we'll make 2 quick questions to address. So, Marie-Josée.
Hi, Marie-Josée Briette from Montreal. I'm a psychiatrist. We know that people with psychiatric condition are at increased risk for acquiring HIV, so I've been having discussions with my department chief about making sure that we facilitate and in fact encourage our outpatients or inpatients to get tested. So I was wondering if you had any advice or suggestions about rolling this out to populations that are emotionally vulnerable, and any adaptations that may have to be made to the model for people who are vulnerable. And by the way, thank you all of you. This was extremely informative and inspiring.
Thank you for your comment. I think for me that was kind of one of the points I was trying to make in terms of trying to think about how we can partner with organizations that have broader mandates than just thinking about testing. And so I think that's where partnerships in different local areas figure out where there are those access points that are possible, to think about the fact that people are going to need different kinds of supports through this process. And perhaps that might be the entry points in as opposed to the referrals afterwards as well. So, yeah.
Nikki, did you have a comment?
Perhaps if when self-tests become available, supervised self-testing at McGill is the way to go.
Okay. Any other comments? Great, we'll take one last question.
So
please.
I apologize, Sean, I'm going to be a bit provocative as the last question or comment.
Great.
Denise Worker from Saskatchewan. So there were some comments around partnering with public health in terms of testing. As a public health practitioner, I agree that public health has a role in terms of providing access to testing for certain high-risk populations or subpopulations. But I think the elephant in the room is that the responsibility for diagnosis and testing, the vast majority of that, rests with the healthcare system. And in a country where we have publicly funded healthcare, why is it that our primary healthcare is not working? And none of you presented any vision about how to improve that.
Thank you. Comments?
I like provocative comments. I think one of the reasons why primary health care is not working from my perspective in Quebec, that I think you don't really have a lot of primary care physicians really taking care of vulnerable populations. A. So that needs to be fixed, and that's a big picture problem. But B, once you have a lot of testing modalities out there, primary care physicians have to engage with the different point of care technologies. What we have gathered in our in trying to understand the contextual factors that are impeding implementation of point of care technologies in Canada, there seems to be a lot of structural and barriers in place. That includes like payment systems. That includes some provinces not allowing lay workers to actually offer point of care testing. It's offered in Africa. Come on, Canada, it can happen here, right? And so innovations, uptake of innovations is going to be the next big hurdle. We are talking about excellent examples of innovations, but we really need to prepare the bed. If the environment is ready, then only we can do it. So we need a lot of dialogue. We need to talk about these things that we don't wish to talk about. We need to engage public health in this mission. And that, I think, is the way to go. The payment models and the business models have really emerged. And also the labs have to be a part of the conversation. Whenever I have to ask companies to give me point of care tests for evaluation in Canada, most of them run away when I say Canada. They're able to give me kits for evaluation outside of Canada. So there's something wrong that needs to be fixed. And it's not just primary care physicians. I mean, they're doing their job. It's the structural thing that needs to be fixed, and we would welcome you to be a part of our conversations.
Yeah, and I think that was my point, is it is about the structural barriers in terms of how things are financed. And I know, having tried to get some salaried funding for HIV physician in Saskatchewan, it was very difficult, but there are no questions asked about fee-for-service. And the biggest structural barriers, I think, unfortunately, are the clinicians themselves and their organizations, but no one, and I'm putting myself out on a limb here, I think that's the case across the country. And provinces have tried to implement primary care models, but they don't necessarily work because of those structural barriers.
Well, thanks, Denise, for that question. I know we're out of time. We'll certainly engage with you and work with you in the provinces to solve those problems. So I just want to say, first of all, thank you for all of you for coming such late in the day. I know the gala is just around the corner, but I want to thank our excellent presenters for their expertise and their innovation and their vision for really solving these problems and bringing solutions to Canada. So thank you all.